Good evening.
Yeah, good evening, sir. Good evening, sir. Sir, now we can see your screen.
Yeah. So, should we start? My apologies.
Yeah, sir. Just like our division head, Mr. Vikas is here. He
Okay.
will be start.
Good evening, sir. How are you?
Yeah, fine. Let us start. I think it's been.
I think, it's getting already late, so we'll just quick start.
Yeah.
And I would extend a very warm welcome, ladies and gentlemen, to you on behalf of Entas. And at the outset, I would like to thank Dr. Ganesh, sir, for giving us this opportunity to be the knowledge sharing partners for this upcoming webinar. And of course, Dr. Ganesh doesn't need any introduction, but Dr. Ganesh, sir, did his MD and DM in clinical hematology and is the lead consultant and HOD at Yashoda Hospital for hematology and BMT. Sir did his postdoctoral fellowship in BMT from Tata Medical Center and then went on to do his fellowship again in leukemia and BMT from British Columbia University, Vancouver. So a phenomenal track record. Sir, over to you without wasting much time, sir.
Yeah. Thank you so much for the kind introduction. I will share my screen now. So.
Yes, sir. Please go ahead, sir.
I hope my screen is visible. I'm audible.
Yes, sir. Perfect.
Thank you so much, and good evening, one and all. Thank you so much at the outset for joining us today evening on a busy weekday amid the ongoing, almost ending COVID pandemic second wave. So I'm thankful to all of you for sharing this virtual platform today evening. And also special thanks to Intas Pharmaceuticals. They are always at the forefront of, conducting academics and, bringing all the support across the medical fraternity, more so in the field of hematology, hemato-oncology. The topic of my talk today is Peri-Partum thrombocytopenia and coagulation abnormalities. Is it really scaring, and can we really have a smart way out amid such dire clinical circumstances? So before I start my talk, I would like to, thank two of my close friends, Dr. Dinesh Pratapwar and Dr. Namdev Bhure, eminent gynecologist and obstetrician from Nanded, and it was them who drove this endeavor of discussing this important academic issue today. So I'm really thankful to both of them. They are doing phenomenal OBGYN work in a district which is world class, and through the interactions, I really sometimes feel amazed the kind of work they are doing. I'm sorry. Sorry for the technical glitch. So also I would like to thank my another friend, Dr. Vinay Bohra, eminent hematologist and a transplanter from Indore, who happens to be my colleague during my DM days. And I owe him a lot of my slides and many of the cases which I am going to present today. So before we start, we are going through a very testifying times of the second wave of COVID pandemic, which has been very devastating, more so compared to the first wave, and most of us have lost our family members near and dear to us. And this talk is in the fond memory of my mother, whom we lost in the second wave, and who has been the at the forefront of bringing us the what we are today. So this is a famous cartoon which has been very widely being forwarded across various social platforms by Damien Barr, a famous columnist. And this is very apt to what we are going through nowadays. All of us, even though are not in the same boat, but we are going through the same storm, and we hope to reach the shore soon, coming out of this COVID pandemic, multiple waves. So My apologies. Somebody might have scratched on this virtual platform, so it's this line is coming in between. But as of today, it's very reassuring that we are the bend the curve is the famous mantra for last almost more than 15 months. So the curve of the second wave in India seems to be quite nicely bending down as of today, and we are towards the tail end of this wave, and that's very really reassuring. Of course, more than the second wave, the subsequent complete resolution of pandemic, what is most important would have been the mass vaccination of the entire population, unfortunately, which is not happening to as per our expectations. But uh, today, I think this after March and April, now the vaccination drive is going to is seems to be picking up, and as of today, as we speak, more than 15 crore population in our country have received more than one dose of at least one dose of vaccine, and meagerly 2 to 2.5 crore have received both the doses, mostly in the medical fraternity. So when the going gets tough, the tough gets going, and it seems to be true of late. So just about COVID-19 management, just like the COVID-19 management, lot of things which have been drastically changing. What was the yesterday's contraindication is today's absolute indication, and which might turn again contraindication tomorrow. So what works and what doesn't is really a dilemma even today, almost 15 months into the pandemic, and I'm sure all of you agree with me that it seems more than a lifetime for us. And there has been an exploding literature on COVID-19, more than 1.5 lakh papers, and you can see week by week there is almost few thousand papers being published in the COVID-19 management. And the sad part, as I mentioned earlier, is that what seemed to be promising therapeutic intervention in the initial observational studies, unfortunately, is being dashed out when put into the rigors of randomized control trials with regard to COVID-19 pandemic. Now, lot of uncertainties, lot of panic, lot of worries about everything with regard to this coronavirus pandemic, and so is true with the vaccine. And I particularly, before I start my talk, I would like to put before this wonderful cartoon, probably 2021 and beyond, this vaccine with the COVID vaccination drive, mass vaccination drive across the society, we are sure to win over this pandemic. And after the pandemic, this cartoon aptly describes, because of these, ongoing uncertainties, unpredictabilities, probably post pandemic, this is going to be the situation across in the medical fraternities. You can see the normal doctors, the medical doctors, inconsistent, but probably psychiatric issues will be on the rise, and that will be the need of the hour. So with that, the background of today's topic is hematology issues are observed very commonly in pregnancy. We can say, considering all the mild cytopenias and all other issues, I think almost 50% of the females with pregnancy will have some hematological abnormalities ranging from mild to life-threatening. Fortunately, only handful of these, like 3 to 4%, need further evaluation and are significant clinically. And here, recognizing and treating these abnormalities are sometimes quite difficult, owing to paucity of evidence available to guide consultants, and that's the topic of discussion today. So the normal physiological changes during pregnancy, there is anemia because of various factors, mostly the hemodilution. So there is 1 to 2 gram drop in physiological drop in the hemoglobin level. There is mild neutrophilia, mild thrombocytopenia, and in pregnancy, from platelet count ranging between 120,000 to 150,000, which is very common physiologically during the third trimester, can be considered as normal. So we are going to discuss issues pertaining to number 1, platelets, and number 2, coagulation abnormalities. So let us start with the cases, the play of platelets in pregnancy, different clinical scenarios, and how we should intervene or how we can actually work to sort out these cases and really decide which are the cases where actual therapeutic intervention is absolutely mandatory, and which are the circumstances, clinical circumstances, we just need watchful waiting without any intervention, and most of them resolve on their own. I request the technical team, can they get this red line off the screen, please? Because I think it's a major distractor. Is it possible?
Sir, actually, this red line it came from your system. You have to just click on this Attonate view option is there, sir. On top, you are seeing view option. You just click on that view option, sir.
Annotate. Okay. So
In Attonate, there is a eraser, sir. Only from your system it can be erased. That's why, sir.
okay, I'll just give me 1 sec. I'll erase it. Got it. Thank you so much.
Welcome, sir.
So thrombocytopenia, particularly with regard to pregnant females, the definition does vary depending upon the gestational period or age. So the definition, for first trimester, platelet count can be normal up to 1.5 lakhs, whereas in third trimester, I just discussed, platelet count of 1 lakh is sufficient. Seen in about 7 to 15% of the pregnancies, and only out of all 1 to 2% have severe thrombocytopenia needing thorough clinical evaluation. And so the approach is going to be very simple. So these are the common hematological abnormalities seen during pregnancy, 7 to 15% thrombocytopenia, and you can see 3/4 of thrombocytopenia during pregnancy is something called a gestational thrombocytopenia, which doesn't require any intervention, and it's very clinically benign, mild, and it resolves on its own after the conclusion of the pregnancy. Whereas other 25%, again, the commonest one is hypertensive disorders, 21%, and ITP 4%, and 1% are other thrombocytopenias. So the thrombocytopenias, for the sake of our better understanding, we can divide those pregnancy specific and which are coincidence. So pregnancy specific are the thrombocytopenias arising out of various etiologies related to the pathological abnormalities in pregnancy, like the hypertensive disorders like eclampsia, preeclampsia, eclampsia, microangiopathic hemolytic syndromes like TTP-HUS, HELP syndrome, antiphospholipid antibody syndromes, and acute fatty liver of pregnancy. Apart from this, the benign one, the majority one, 75% gestational thrombocytopenia. Whereas the coincidental thrombocytopenias, you can see ITP, that is immune thrombocytopenia, which may be pre-existent before the confirmation of pregnancy, or which can have its onset right during the pregnancy, which can in many circumstances resolve with the conclusion of the pregnancy, and in other circumstances which will continue even after the pregnancy. So other coincidental causes like drug-induced thrombocytopenias, various infections, hematological issues, and underlying autoimmune disorders like lupus being the commonest one. So when a lady with pregnancy presents with thrombocytopenia, what all things you should discuss or think about is what trimester, which trimester of pregnancy, how severe it is, what is the pace and trajectory of this development of thrombocytopenia, the pre-pregnancy results, associated symptoms, and associated lab abnormalities. So, this is the diagnostic algorithm for the females presenting with thrombocytopenia in pregnancy. The most important one is the well-read peripheral smear by pathologists to segregate the pseudo-thrombocytopenias because of either anticoagulant like EDTA, induced the platelet clumping, which can lead to artifactual thrombocytopenia. When the platelets are really low on peripheral smear, then you divide based on the various abnormalities observed on the peripheral smear. So depending upon the different peripheral smear abnormalities, you can divide the various etiologies into different groups. So, in hematology, what is very crucial is this peripheral blood smear and the hemogram as a tool to look at various hematological possible abnormalities. So like the famous saying in hematology, like a like an ECG for cardiologists, for like endoscopies for gastroenterologists, and various imaging like CT, MRI for neurologists. Hemogram generated by this cell counter machine is a very vital tool to look at various possible hematological abnormalities in such cases. And by hemogram, I mean not only just the numerical values, but also these histographical values, which can give us a very vital clue. I can vouch, in more than 90 to 95% cases, you can have some diagnostic conclusion, or at least reasonable differentials ready based on the interpretation of these hemograms. So such a vital tool. So like the famous saying, eyes are useless when the mind is blind. So these mental algorithms with regard to hemogram reading can be very vital in evaluating various hematological abnormalities arising in pregnancy. Now coming to thrombocytopenias according to different gestational age. So mostly in the first trimester, the immune thrombocytopenias. In second trimester, again, ITP, the immune thrombocytopenias or other causes of thrombocytopenia are common. Whereas in the third trimester, the most predominant one, 3/4, when the platelet count is just mildly suppressed, ranging between 80,000 to 1.2 lakhs, is gestational thrombocytopenia without any clinical evidence of bleeding. Whereas those with severe thrombocytopenia, the major chunk, 3/4, is comprised of the hypertensive disorders of pregnancy like preeclampsia, eclampsia, and HELP syndrome. And others are uncommon, like acute fatty liver of pregnancy, TTP, and ITP. So, based on this, you can devise the predominant etiology underlying thrombocytopenia across various gestational ages. Like the first trimester, ITP is common as. Second trimester, again ITP is common as, along with other associated the hematological abnormalities like the hypertensive disorders of pregnancy, gestational thrombocytopenia, though not as common as in third trimester, but can be seen right in the second trimester, with the platelet count hovering around 80,000 and above. In third trimester, again, when the platelet count is mildly suppressed without any bleeding manifestations, the gestational thrombocytopenia comprises the major chunk of thrombocytopenia. Whereas symptomatic severe thrombocytopenia, this is an alarming condition, particularly during the third trimester, because this can underlie various life-threatening conditions leading to thrombocytopenia, like the hypertensive disorders of pregnancy. Now, thrombocytopenia in pregnancy has implications not only to mother, but it has implication to the fetus also. And these are the various, this is one of the common thrombocytopenia etiologies, ITP, particularly first and second trimester, and this is management guideline algorithm. So when the platelet count is more than 50,000, as you can see here, during any trimester, there is no therapeutic intervention required except watchful waiting. Whereas the platelet count, again, 30 to 50,000, third trimester steroids, but first and second trimester, most of the patients with such modest thrombocytopenia don't have any bleeding manifestations and then don't require any therapeutic intervention. This is very important. I like to draw your attention here. Many a times I see patients with pre-existing ITP or ITP diagnosed during pregnancy, first and second trimester, with platelet count far above 30,000 without any bleeding manifestations. Many of us, alarmingly or in that apprehension, keep on intervening with various therapeutic strategies where risk may outweigh the benefits offered with such therapeutic interventions. Again, coming to platelet count 10 to 30,000, any trimester, if no bleeding, steroids, but if there is active bleeding, because this is severe thrombocytopenia, most rapid acting agents like IVIG or anti-RSD can be required. Again, here, even with patients presenting with this count, for first and second trimester, steroids alone are sufficient. But if the patient is near term and you need platelet to come to a hemostatically safe level, then the IVIG can be a vital tool. Now again, the platelet count less than 10,000, any trimester, steroids with or without IVIG is mandatory. And if the patient is bleeding, platelet transfusions can also be justified. Now the goal therapeutically safe, hemostatically safe target platelet count is 30,000 throughout the pregnancy and 50,000 near term for any obstetric intervention except neuroaxial anesthesia, where platelet count of 80,000 to 1 lakh is mandatory, because any slightest of bleeding in the neuroaxis can have catastrophic consequences. So barring neuroaxial anesthesia, platelet count of 50,000 is hemostatically safe for obstetric interventions like cesarean section. Now, the case scenario one, which the young lady who has a asymptomatic modest thrombocytopenia, you do again, gestational thrombocytopenia is a diagnosis of exclusion. So all the workup has to be completed. This lady has third trimester, she's in her third trimester and she has modest thrombocytopenia. So all autoimmune profile and infectious profile is negative. Peripheral smear, except modest thrombocytopenia, there is nothing. And she was diagnosed here with ITP. Of course, the bone marrow is not mandatory, but it was done. And so she has modest thrombocytopenia. She has no ongoing bleeding manifestations. Does she need treatment? And if at all, what should be the therapeutic options? So her platelet count till completion of second trimester were hovering between 50 to 60,000, and she has no significant bleeding manifestations. So that's why we didn't intervene with any therapy till she entered into her third trimester. Again, at 34 weeks, her platelet count was found to be 36,000. Now, what should be done here and what should be the mode of delivery here? You can see here, platelet count threshold for various, obstetric interventions like cesarean section, 50,000 is enough. Normal vaginal delivery, 50,000 is enough, but spinal anesthesia, 75,000 to 1 lakh. And again, the mode of delivery has to be based on the obstetric indications. The underlying hematological conditions, like the ITP, is not going to determine the obstetric intervention for completion of pregnancy here. Now, coming to second case, she has modest thrombocytopenia, most likely gestational, again a diagnosis of exclusion. But given the past history of lupus, thorough evaluation to rule out ITP was done. Here she was continued with every 4 weekly CBPs and with close monitoring. So like the famous cartoon here, the underlying etiology need to be addressed when dealing with the thrombocytopenia in pregnancy. This is again for the simplification of understanding a flowchart for thrombocytopenia during pregnancy. Most important one is associated abnormalities and the prior history of ITP, and well-read peripheral smear can conclude with appropriate diagnosis in most of the cases. So take-home message from these two thrombocytopenia cases is coincidental causes remain the most common etiology, as I highlighted in one of the graphs before, gestational thrombocytopenia being the commonest one during second and most common during the third trimester, comprising 3/4 of cases of thrombocytopenia in pregnancy. It is again a diagnosis of exclusion. A minimum workup required is well-read peripheral smear along with a well-read hemogram and LDH and autoimmune profile and infectious serology. Routine practice of giving steroids may not have any impact in patients with gestational thrombocytopenia. Here, risk outweighs the benefit. In fact, gestational thrombocytopenia, a close watchful monitoring with periodic CBPs what is enough, and reassurance of the patients and families is enough. Of course, the platelet count usually hovers around above 70 to 80,000. So minimum platelet count, as I mentioned earlier, for uneventful pregnancy is 50,000, which is maintained most of the times in gestational thrombocytopenia. Now, changing gears further. So the other side of the coin. So what we saw was the bleeding patient. Now, because of thrombocytopenia, this is a 32-year old lady who is primigravida. She has eclampsia and she has intrauterine fetal demise, which was delivered by LSCS. There was no excessive bleeding during LSCS, but on day 2 post-op, she develops high-grade fever, large ecchymotic patches on the pressure areas of body, on her lower limbs and on her trunk, and there is profuse oozing from the stitches. Now, this is her lab evaluation. You can see there is modest anemia, leukocytosis with neutrophilia, and modest thrombocytopenia, but the creatinine is high, 2.1. The INR is high. The PT APTT is grossly deranged, so she has coagulopathy, modest thrombocytopenia, fibrinogen is normal, FDP is high, and on other lab parameters like imaging, the ultrasound abdomen shows a retroperitoneal collection, and on urine evaluation there is plenty of RBCs, so she has macroscopic hematuria, and there is mild conjugated hyperuremia, and blood culture grows gram negative bacilli. So this is what is the diagnosis, what should be the medical management. I'm sure you will agree by now, all of you might have come to a conclusion of DIC secondary to puerperal sepsis and what is new in the DIC management. So this case is very simple, straightforward, postpartum sepsis leading to DIC with coagulopathy, thrombocytopenia, and profusely bleeding patient. And that's what is something which is very alarming in our clinical practice. And this is like the famous saying by Professor Albert Einstein, if you can't explain it simply, you don't understand it well enough. And this clinical picture itself is conclusive of the DIC diagnosis. DIC is always secondary to underlying etiologies, like here sepsis due to intrauterine fetal demise. So it goes without saying that unless the underlying cause of DIC is treated, DIC can never be completely controlled. So DIC in pregnancy, whatever the precipitating event, there is activation of coagulation cascade, which leads to excess thrombin generation, which simultaneously leads to excessive clotting, mostly in the microangiopathic thrombosis, microvascular as well as macrovascular clotting, which also because of this excess thrombin also leads to activation of plasminogen, which leads to fibrinolysis. In constellation with thrombocytopenia, this leads to excessive bleeding, and the bleeding can be so profuse that the patient will, if not attended in time, can quickly go into hypotension, shock, and multi-organ failure. At the same time, the other side of the coin is because of extensive microvascular thrombosis, there will be excessive microvascular thrombosis leading to widespread ischemia and impaired organ function leading to multi-organ failure. So DIC in pregnancy has two bullets. The first one on the coagulation cascade leading to thrombotic microangiopathy, and the second one being the consumptive coagulopathy leading to excess bleeding. So the most important hallmark of DIC is thrombotic microangiopathy leading to organ damage, and parallelly on the other side there is excessive hemorrhage, which is characteristic hallmark of DIC, more so in pregnancy. Now, as I mentioned, this is again a schematic, simplified version of DIC in nutshell. So one side, systemic microvascular thrombosis leading to organ failure, and the other side, consumptive coagulopathy leading to excessive bleeding. Now, coming to causes of DIC, the commonest one is the etiologies where DIC is very high, like abruptio placenta, almost half of them develop DIC. The second, hypertensive disorders of pregnancy like preeclampsia, eclampsia help. Almost 1/4 to half of them eventually evolve into DIC if not managed well, or in many patients, even after prompt diagnosis and successful management, can eventually lead to DIC. Other rare disorders like acute fatty liver of pregnancy, even though this etiology is rare in pregnancy, but in patients with happening in 1 in 10,000 to 1 in 15,000 pregnancies, but in those etiologies, almost 3/4 of this acute fatty liver of pregnancy can eventually develop DIC. Amniotic fluid embolism, and as we discussed, the septic abortion, massive hemorrhage, either intrapartum like abruptio placentae or placenta previa, intrapartum like ruptured uterus or placenta accreta, or postpartum like massive postpartum hemorrhage can lead to DIC, and intrauterine fetal demise can also lead to DIC. So the etiologies can be different and their management is different. DIC distinction from other rare etiologies, of course, TTP in pregnancy in isolation is rare, But here, the the common differentials is that the DIC is associated with coagulopathy, whereas TTP coagulopathy is not seen. The LDH is extremely high, disproportionately high in DIC. It can be modestly elevated. LDH is extreme. I beg your pardon. LDH is very high in TTP, whereas it is modestly elevated or normal in most circumstances in DIC. And why this is distinction is important, because plasma exchange is a mainstay of therapy of thrombotic microangiopathy like TTP is not useful. In fact, it is contraindicated in DIC. So treatment of underlying cause and massive transfusion protocol is the mainstay of DIC management. So DIC is very life-threatening complication of various underlying etiologies, and if you prompt diagnosis is not made and the therapeutic intervention is not immediate, many lives can be lost. So it is catastrophic. So lab evaluation, the standard prothrombin time, partial activated partial thromboplastin time to evaluate various coagulation pathways. So we all know that hemostasis is comprised of three phases. The first phase is the primary hemostasis, where at the site of vascular damage, platelet in constellation with fibrin form a temporary plug, which is subsequently which acts as a scaffold for second phase of coagulation cascade activation. And the third phase is antithrombotic system. In normally under physiological circumstances, there is antithrombotic system in place to check the excess activation of thrombosis, and the third phase is fibrinolysis. All these things would have been best evaluated through a very simple and the most modest tool to evaluate overall thrombosis and hemostasis in nutshell, and that is thromboelastography. And what we see here is like graphs which can be obtained within 10 minutes, and based on just a brief look for an experienced observer of various graphs, and their interpretation can lead to understand the underlying primary hemostatic defect in these cases, and based on which you can devise your therapeutic intervention. This is how a normal thromboelastography graph results can be seen. So there are various parameters here, various waves, various angles. So, and based on these abnormalities, you can devise whether various coagulation factor replacements, how they can be helpful in these various hemostatic abnormalities. Now, coming to hypertensive disorders, preeclampsia, probably I'm a student amidst all the august audience here of obstetricians and gynecologists. These terminologies are very common in your practice. So preeclampsia, hypertension, proteinuria, edema, very common, occurring in almost 2 to 6% of all pregnancies, of which 20 to 50% may develop various degrees of thrombocytopenia because of consumptive coagulopathy. And overall, despite thrombocytopenia, hemorrhage is uncommon unless these patients evolve into overt DIC. Now, coming to health, the hemolysis, elevated liver enzymes, and low platelet. Here, the thrombocytopenia is moderate, and again, like the various hypertensive emergencies in pregnancy, the prompt delivery and various other management of underlying etiologies is very crucial for successful outcome of these complications in pregnancy. Now, coming to thrombotic microangiopathies like TTP-HUS, the classical pentad quite rarely seen, but what is important here is neurological dysfunction, renal failure, and peripheral smear showing schistocytes with evidence of hemolysis. And the treatment, as I mentioned earlier, is prompt plasmapheresis along with immunosuppressive therapies and steroids, which can be life-saving in these circumstances. So DIC, the classical signs and symptoms of severe bleeding, as I mentioned you earlier, the intrapartum, postpartum, and prepartum, skin oozing because of extensive consumptive coagulopathy, which on the other hand can have disseminated microthrombi in the circulation, leading to various organ failures, the hemorrhage leading to shock with classical findings of tachycardia, hypotension, and various organ dysfunctions and multi-organ failure like acute oliguric renal shutdown. And this is signs and symptoms of DICs are very well described, but most of the clinical circumstances, the picture is so revealing. The diagnosis is clear in most of the circumstances. So diagnosis, the first and foremost is the clinical scenario based on the signs and symptoms, and then the lab evaluation, which shows these coagulation abnormalities like coagulopathy with raised PTA, PTT, and various degrees of thrombocytopenia. Hypofibrinogenemia occurs late in the course. By the time the DIC is quite widespread, quite advanced, and the patient with hypofibrinogenemia has very high mortality. So early suspicion, clinical suspicion with prompt therapeutic intervention is vital for successful outcome in these clinical circumstances. Now, DIC in patients with jaundice, this is again a very important differential of DIC, various underlying etiologies underlying DIC in pregnancy. Most of these happen during third trimester, and based on the simple parameters, the liver function test, the coagulation profile, and the blood pressure, you can distinguish across various etiologies like acute fatty liver of pregnancy. The patients have predominant hepatic dysfunction, hyperbilirubinemia, clinically overt coagulopathy, whereas in patients with HELP syndrome, which is most of the times in patients with underlying preeclampsia, eclampsia, with hypertension, very, very important to distinguish from other patients with jaundice presenting with DIC. And here in HELP syndrome, these patients have various degrees of thrombocytopenia, but coagulopathy, overt coagulopathy, unless and until in the very late advanced stages, is not seen. Again, acute fatty liver of pregnancy is a medical emergency with a very high maternal and perinatal mortality ranging between 25 to 15 to 25%. Whereas in HELP syndrome, again, if prompt intervention is not sought, it can also lead to very high maternal as well as perinatal mortality. Now, management essentially revolves around the identifying and correcting the underlying cause, at the same time trying to stabilize the patient with patients with hypovolemic shock or post hemorrhagic shock, hypotensive shock. IV access and prompt IV replenishment is very, very important. Patients with hypoxia, oxygenation, and anesthesia team is the specialist which can really help in stabilizing these patients with management of various organ dysfunctions. Now, lab workup with repeat coagulation parameters being repeated every 30 minutes till the patient is stabilized, until the overt coagulopathy is corrected. Based on the lab workup, you have to initiate massive transfusion protocol wherein you transfuse all blood components in 1:1 ratio with PRBCs, platelet, FFPs, and cryoprecipitators. Now, coming to the fetal status, which can really decide the subsequent course. If the fetal status or the fetal viability is reassurable, then first stabilize the mother, hemodynamic stabilization of the mother with end organ dysfunction correction, and transfusions, massive transfusion protocol initiation, transfusions, and hemodynamic stabilization. And then if the fetal status is still the fetus is viable, again reconfirm and plan the termination of pregnancy after correction of after control of the hemorrhage as well as coagulopathy. Here again, most of the times the vaginal delivery is something which is recommended, but if, unless and until it is emergent situation and the vaginal delivery is not feasible, then the LSCS can be attempted. Again, the fetus where the pre-viable fetus or fetus already there is fetal demise in the second trimester, as much as possible try to start induction or dilatation and evacuation. And if the third trimester, as much as possible avoid operative intervention, and unless and until absolutely indicated, should be tried to induce and dilatation and evacuation. Now transfusion management, blood product transfusion and simultaneous management of these coagulation parameters go hand in hand, as I mentioned earlier, every 30 minutes, because it is a medical emergency. Prompt correction of coagulopathy is as well as ongoing massive hemorrhage is something which is very, very crucial, failing which the mortality can be quite high. So as I mentioned earlier, the 1:1 ratio of all the blood products is important with PRBCs, FFPs, platelets, and cryoprecipitates. So how much blood product to be ordered? Immediately after clinical suspicion, reserve at least 6 units of PRBCs, 2 units of FFPs, 6 units of RDPs, and 10 units of cryoprecipitates. And based on the coagulation parameters, keep on replenishing till the parameters starts recovering. So the platelet count above 50,000, the fibrinogen level above 100, and the PT APTT within 1.5 times to control value is something which is expected, which is what we opt for or aim for. Now, with regard to the various blood product transfusions, PRBCs, we all know 1 unit PRBC raises the hemoglobin by 1 gram percentage. So depending upon the severity of anemia, you can plan the number of units to be transfused. You can safely transfuse up to 4 units within 24 hours. So 1 unit every 6 hours, along with simultaneous replacement of the other 1:1 blood components like FFPs, cryos, and platelets. At least give 12 hours before change in hemoglobin is reflected on subsequent hemograms. With regard to FFP, again, FFP contains all coagulation factors except those in the cryoprecipitates, and FFP has to be ABO specific, though RA specificity is not required, and FFPs are not cross-matched. So the dose recommended is 15 ml per kg per day, which can be divided into 3 to 4 doses over 24 hours, so that patient doesn't end up with rapid transfusion associated cardiovascular overload leading to compromise. So for practical point, for a 60 kilogram woman, the dose recommended as per her weight comes around 900 ml. So we can devise 1 FFP every 6 hours. So advantage of this policy is avoidance of fluid overload, and simultaneous and sequential infusion of other 1:1 blood components can be continued. So coming to cryoprecipitates, again, should it be each and every patient? No. Patients with hypofibrinogenemia, it is a viable tool. Each bag of cryoprecipitate contains about 10 to 20 ml. So the transfusion dose is 1 unit of cryo per 10 kilogram body weight, which will raise fibrinogen by a factor of about 50. And again, cryoprecipitates are non-group specific and no cross-match is required. So average 10 to 12 cryo bags are required daily based on the patient's weight. Now coming to platelets, the platelet transfusion threshold is around 10 to 10,000 below, thrombocytopenia with platelet count less than 10,000. In an actively bleeding patient, threshold should be kept above 50,000. And in non-bleeding patients, 10 to 20,000 is the threshold for platelet transfusions. So again, here threshold depends not only on thrombocytopenia alone, because in DIC, because of consumptive coagulopathy, one hand there is widespread microvascular thrombosis, on the other hand consumptive coagulopathy leading to depletion of various coagulation factors manifesting with bleeding. So bleeding is not solely because of thrombocytopenia. So other simultaneous deficiency of coagulation factors reflected through coagulation parameters like PT, APTT, fibrinogen should be taken into consideration while devising the number of units of platelet transfusion. Usually one random donor platelet, 1 RDP bag per 10 kilogram of patient body weight raises the platelet count somewhere between 10 to 15,000. So other, coagulation factor concentrates like fibrinogen concentrates, activated prothrombin complex concentrates, recombinant factor 7 are not conventionally used in patients with DIC in pregnancy unless and until patient is profusely bleeding and the life, the life risk is very high, and you are in a dire need of achieving hemostasis. Barring those emergent circumstances, FFPs, cryoprecipitates, platelets, and PRBCs in 1:1 ratio by way of massive transfusion protocol is what is recommended for management of DIC. Now, monitoring at least twice daily CBC, at least once daily coagulation parameters with PTA, PTT, fibrinogen. If patient is actively bleeding in various organ dysfunctions, you can order till the hemostasis is achieved the coagulation parameters every 30 minutes to 1 hour also. Now the goal, as I mentioned earlier, hemoglobin 9 to 10 grams, platelet 50,000, PTA, PTT less than 1.5 times the normal control value, and fibrinogen at least above 100. Again, no role of FFP or cryoprecipitate transfusion if PT and APTT are normal, even if the patient is bleeding. And unless and until the underlying cause is treated, DIC will not resolve completely. And platelet rise will be better with single donor platelets than the RDPs. But in the emergent circumstances, start with RDPs and then plan SDP transfusions. So, like the famous saying, the Telugu cinema suspense, why Katappa killed Bahubali, fetching highest revenues for Bahubali 2. This why for each of therapeutic intervention and monitoring is crucial in such life-threatening complications. Now, switching gears further, when blood is thicker than water in patients with pregnancy, this is 26-year lady comes to emergency department. She is hemodynamically stable. She is 24 weeks primigravida. She had history of seizure following headache since 1 day prior to her visit here. She was started on anti-epileptics at local hospital and was referred here for further evaluation and management. She denies any history of fever, any localizing signs, symptoms, or loss of consciousness post that seizure episode, and she had history of similar symptoms in the past. And ultrasound abdomen confirms live 24 weeks pregnancy. And this is her workup: hemoglobin normal, WBC mild, leukocytosis, platelet normal 4 lakh 20,000, PTA, PTT normal, and MRI brain reveals thrombosis in the superior sagittal sinus. Now, we know the diagnosis. What is the risk of thrombosis in normal pregnancy? How it should be managed? What should be done in the postpartum state to avoid complications? And what are the issues with regard to this therapeutic anticoagulation in postpartum females who are breastfeeding? So these are all issues which comes to our mind in managing such cases. So diagnosis is acute superior sagittal sinus thrombosis. The antenatal postnatal venous thromboembolism happens compared to normal population. The incidence is 10 to 25 times is more common in the pregnancy. Now, this happens because of the loss of balance between coagulation and anticoagulation system in our body because of the various triggers during thrombosis, during pregnancy. Now, what are the red flags of thrombosis in normal pregnancy? So, asymmetrical painful swelling of lower limb, sudden onset of or new onset breathlessness, unexplained abdominal pain, and unexplained visual complaints. So, 50% of thromboembolic events will occur in patients without any risk factors. And I will like to draw your attention here. Pregnancy itself is a risk factor. It's being a prothrombotic state for various thrombotic manifestations. Now, who should be screened for thrombophilia? Those who have a history of family history of venous thromboembolism, who have unprovoked VTE, where VTE happens in females less than in patients less than 60 years old, recurrent VTE, unusual site VTE, and suspicion of antiphospholipid syndrome. The screening makes sense only if you are having all these factors in the history where the screening will help us in modifying the subsequent risk of redevelopment of the thrombosis and embolism in these patients. So whereas thrombophilia the various thrombophilia predisposition in pregnancy, commonest is factor 5, factor 2 mutations, 4.6 per 100 thrombotic events during pregnancy. Others are rare. Again, factor 5 leader is very common of all the thrombophilia predispositions. So how it should be managed? The treatment of VT in pregnancy is heparin throughout and at least 6 weeks postpartum. Unfractionated heparin has largely been replaced by LMWH, and the dose is 1 milligram per kg subcutaneously twice daily. So try to avoid direct oral anticoagulants and vitamin K antagonists because of the risk of fetal adverse events. So what are other important factors in postpartum state to avoid complications? Early mobilization, adequate pain control, and adequate hydration during parturition and in the postpartum period. Continuation of anticoagulation for at least 6 weeks postpartum is important. Other pregnancy related or other circumstances where anticoagulation is of paramount importance in these thrombophilia predisposed patients is patients with requiring ovarian stimulation. In those patients, thromboprophylaxis with low molecular weight heparin is optimal. Again, going back to the so we have to think differently in managing these patients. So again, during breastfeeding, extensive data available to support the safety of low molecular weight heparin. Warfarin is also found to be safe in the breastfed mothers. No hemorrhagic complications is reported in neonates, and duration of anticoagulation at least 6 to 12 weeks postpartum, apart from throughout pregnancy. So with the exception of antiphospholipid antibodies, there is little evidence to support systemic screening of thrombophilia in a woman with already complicated pregnancy. So in these circumstances, combined treatment with low molecular weight heparin and antiplatelet aspirin with close monitoring, although not validated as safe and efficient, but is helpful in preventing recurrent complications associated with thrombotic episodes. So the antithrombotic therapy in these kind of complicated pregnancies with thrombophilia predisposition is dual anticoagulation with antiplatelet aspirin and low molecular weight heparin. Stop aspirin at week 34, continue low molecular weight heparin until 4 to 6 weeks postpartum. And for women with past history of eclampsia and or preeclampsia and no thrombophilia, low dose aspirin alone is recommended. So to conclude, hematological issues are quite common during pregnancy. Prompt hematology referral and teamwork. I like to draw your attention here. Together, everyone achieves more in the teamwork is helpful in managing those cases. And most hematological cases, I'm sure you will agree with me, appear more scary than they actually are during the pregnancy. So like the famous saying, coming together is beginning, keeping together is progress, working together is success. And all these complicated and so-called scary and quite difficult to manage cases can be tried to be sorted out through teamwork. So like the famous theorem of Darwin, it is not the strongest of the species that survives, not the most intelligent one, but the one who is most responsive to change. And I am sure this is COVID-19 pandemic has again re-emphasized this fact to the constant change in our approach to have a better chance of better outcomes in these difficult to treat scenarios with teamwork is something which can really help us in sorting out these cases. And before I conclude, we all know that we are towards the end of the second wave of this pandemic. Hopefully third and fourth wave which are a lot of speculations happening across, should not come to us. But till this COVID pandemic is totally over, let us continue with the the age-old formula of prevention. This cartoon here is of the 12th century black pig doctor wearing a fancy PPE kit with this fancy mask, face mask of a shape of a bird beak, because it used to be stuffed with herbs and flowers to protect them from the foul smelling stench of so many coffins and dead bodies lying around. Again, the same principle of staying home and keeping social distance with appropriate protective measures is what even 9 centuries have passed by, but the mainstay of managing any pandemic like COVID pandemic remains the same. So with that, I will thank one and each one of you for patient hearing, and I hope my talk on these hematological issues in pregnancy will be of some use, and if at least 1 to 2% of any take home message through my discussion if you carry, I will feel that will succeed my talk. And I know we are exceeding our time slot, but I'll be happy to answer if there are any queries on this virtual platform. Thank you one and all, and take care, stay safe.
Thank you, sir. Thanks for such a lucid presentation over the such important topic. Now, I'll request audience, either they can post their queries in chat box, or they can unmute themselves one by one and ask the questions to sir.
So
We have allowed the audience, they can unmute themselves.
Good evening, everyone, sir. Sir, that was wonderful. I joined a little late. Can I have the recorded version of your lecture?
yes, madam. We will forward you across the recorded version, and Intas Pharmaceuticals team has agreed to post it on YouTube, as well as forward the recordings to all the attendees.
Okay, sir. Thank you, sir, because I joined late, and sorry for that. But I'm very keen on listening to your lecture.
Yes, madam. I will forward. I will make sure it reaches to the recording version. Thank you, madam.
Thank you, sir. Thank you very much. భద్రంగా దాచిపెట్టు
Sir, we have Dr. Nisha, Dr. Santoshi, Santu, all are thanking you very much, sir, for this presentation. They all love the presentation.
I thank all of you for this. At least more than webinar, I personally feel connecting with each other personally, even though on a virtual platform, is very reassuring amidst the most testifying times. And I thank all of you for joining today amidst the hectic, after the conclusion of the hectic work on a weekday. Thank you, one and all. And I'm really grateful for all the, remarks. And hopefully we should have many academics on virtual platform at the comfort and ease of our, without disturbing our day-to-day routine. Thank you.
Sure, sir. Sure, sir. Sir, there is one question which came. It is that if we don't have the facility for testing, how can we clinically assess and diagnose different disorder?
This is a, thank you so much for bringing this question on this platform. This is a very, very crucial and vital issue pertinent to pregnancy associated complications, more so with DIC, and, which is very life threatening. So I can understand at, primary and secondary care setups, all these gadgets, the diagnostic gadgets like even simple coagulation profile with PTA, PTT might not be available. But yes, even though I mentioned earlier that the bleeding time and clotting time is absolute with the availability of these modern, diagnostic tools. But yes, under such clinical, setups, even though bleeding time and clotting time is absolute, but this can form a vital tool to assess the integrity of coagulation cascade, hemostasis, and based on these BTCT I'm sure a lot of our colleagues are still relying on BTCT, and particularly those practicing obstetric, which is part of acute care or emergency medicine, and there probably due to lack of these minimum required coagulation parameters like PTA, PTT, fibrinogen assay, BTCT can be a vital tool in assessing the response as well as the intensity of the coagulation factor defects. And based on these, the traditional tests, you can continue replenishing the blood components to overcome the hemostatic catastrophes.
Thank you, sir.
BTCT is the cheapest and safest and most reliable test, sir, which we have been doing it.
I
long
do
time.
agree. Yes, because under these life-threatening circumstances, clinical scenarios, even though BTCT, yes, it is a vital tool, but it has a lot of subjectivity associated with it, because who does, how it does, for example, the bleeding time, the length of the incision, the depth of the incision, and the subjective assessment of the technician of how
Yes.
how deep and how frequently he monitors it. It is very subjective. Even if I do bleeding time on my two arms, the results will be
Maybe
different from
yes.
each other. So because of it, of
Yes.
course, it is a vital tool if it is done under ideal, technical, as per ideal technical recommendations. It is a vital tool, but because there is a lot of subjectivity associated with it,
Yes.
typically when we have these other robust parameters like PTA, PTT, which the subjective variability is not much, and that's how they are vital tools in monitoring the such DIC
Yes, sir.
effects.
This is what, sir, in resource.
Sir, Dr. Bindu Madhvi had asked that what is the significance of PT, APTT, and INR? What each factor indicates?
So basically, the coagulation cascade I just briefly mentioned earlier, the intrinsic pathway and the extrinsic pathway. So PT and APTT. PT assesses the intrinsic pathway starting from factor 7, and APTT assesses the intrinsic pathway of the coagulation cascade. And based on these lab values, you can have an idea of the underlying defect, and accordingly you can devise coagulation factor supplements for the correction of coagulopathy in patients with DIC. Dr. Bindu Madhav madam has again, are we supposed to do PTA, PTT and INR routinely? As I mentioned you earlier, the clinical circumstances, the clinical scenario, the signs, symptoms of underlying, etiologies leading to DICs are very obvious. So clinical suspicion, high index of suspicion is very, very important in suspecting DIC. And once you have a clinical suspicion of DIC, you have to, monitor PTA, PTT very stringently, along with supplementation of, along with activation of massive transfusion protocol. And in the dire circumstances when patient is profusely bleeding with multi-organ dysfunction, PTA, PTT has to be repeated every half an hour to 1 hourly till you correct as per the various target parameters like platelet count more than 50,000, PTA, PTT at within 1.5 times the normal control value, fibrinogen more than 100. So these are the parameters which you should monitor in an actively bleeding patient with ongoing DIC with multi-organ dysfunction. So Dr. Kalwa Sampurna madam has asked, by the time the blood products are available, is there a role of IV fluids? Absolutely yes, madam. Most of these patients, in acute DIC, they are at risk of hemodynamic geopathy. So most of them are hypotensive. So prompt correction of hypotension with IV fluids, prompt correction of acidosis, prompt correction of hypoxemia with oxygen supplementation is of paramount importance to safeguard the lives of these patients, these critically ill patients, till the time the blood components are available for transfusion. Dr. Shivdayal sir has asked bedside clotting time, how frequently to be done in intrauterine, IUFD. So not all patients of IUFD, once you diagnose IUFD, I am sure your strategy is to get the fetus out as early as possible. So if the patient is not in acute DIC, not suspected to have an acute DIC, you can continue monitoring clotting time at least once or twice a day if there is no active bleeding and there is no evidence, clinical evidence of ongoing or impending DIC. Whereas the patient in active DIC, apart from the planning to get the dead fetus out at the earliest possible time, clotting time should be monitored based on the clotting time abnormalities. If the clotting time is grossly abnormal, continue activate the massive transfusion protocol with 1:1 blood components and keep on monitoring clotting time every 6 to 8 hourly till the clotting time done under appropriate technical recommendations is within the acceptable range. So Dr. Srivani madam has asked, is there any physiological rise of D-dimers in pregnancy? Yes, as I mentioned earlier, D-dimer, pregnancy itself being a prothrombotic state, we don't routinely monitor D-dimer. It will be invariably high unless and until you are suspecting pulmonary thromboembolism. So you should not rely on D-dimers heavily because the picture is very confounding. The already pre-existing high D-dimers can confound the picture. So what is most important is the coagulation parameters and various organ function parameters like creatinine, the respiratory parameters, the cardiovascular parameters, and based on that you have to continue. So DIC as a broad diagnosis, the underlying causes leading to DIC can present either in a patient with profuse bleeding profile, like most of the pregnant patients. In pregnancy, the DIC has predominantly bleeding profile, whereas other circumstances like cancer-associated DIC associated with various autoimmune disorders, there the thrombotic component is more dominant with regard to clinical presentation. So in bleeding, in pregnancy associated DIC, most of the times it is the bleeding profile, and so monitoring the coagulation parameters and supplementing the blood components is of paramount importance, very vital to safeguard their lives. Whereas D-dimer, a marker of thrombosis, unless and until the clinical circumstances demand, should not be repeatedly done because it will confound the picture. Dr. Kalwa Sampurna madam has asked, is there a risk of fluid overload with IV fluids? Of course, in a patient who is in shock, hypotension because of ongoing DIC, the risk of fluid overload is far negated by prompt fluid replacement to maintain the hemodynamic stability. So there will always be risk of fluid overload, but titrating the vital parameters of heart rate, blood pressure, urine output, you have to keep on supplementing IV fluids till you get the blood components. So another esteemed faculty has asked, if ABG is not available, what is the alternative? If ABG is not available nowadays, thanks to COVID pandemic, everybody across the society knows monitoring pulse through pulse oximeter, and then pulse oximeter is now quite rampantly available across. So oxygen saturation is something which can be used along with the other parameters like lactates and other parameters of coagulation or hemostatic defect based on the clinical circumstances. Another esteemed faculty has asked, is any term chronic DIC in pregnancy? Yes, there is a chronic DIC also in pregnancy, where like classically happens with abruptio placentae. during the second and third trimester, the chronic DIC is there. But the chronic DIC clinically is not of very overt presentation and the overt or emergent presentation. So based on the underlying factor, you have to plan the management of the pregnancy as well as the coagulation abnormalities seen in this. Whereas in acute DIC, like we discussed today, it is a medical emergency. If not attended in time, it will have catastrophic, devastating consequences.
Correct.
Role of thromboelastography in management, as asked by Kavita madam. Yes, I mentioned you earlier, thromboelastography is a very most modern hemostatic monitoring tool. And as I showed you, just graphical representation, the results will be out within 10 to 15 minutes. And if you are well versed in reading these thromboelastography graphs, you can have a quick idea of what might be underlying hemostatic defect, and according to hemostatic defect, you can plan the coagulation factor replacements like FFPs, cryoprecipitates, or platelets based on the underlying coagulation factor defects. Many a times hyperfibrinolysis, which happens in a well-established full-blown DIC, based on this, you can plan the antifibrinolytic agents you can avoid antifibrinolytic agents like tranexamic acid, epsilon caprylic acid. So like that. So based on the TEG graph, you can devise your coagulation factor replacement strategy. Dr. Srivani madam has asked physiological rise in D-dimer. Yes, pregnancy being a prothrombotic state, there is physiologically the D-dimers are found to be high, particularly in second and third trimester of pregnancy. If you do, you will find it always high in the pregnancy. I hope we have addressed.
So you have addressed nearly all the questions as of now. What has been posed by
another question by Dr. Lakshmi Kosuru madam. INR would be useful only when patient on anticoagulant. Is it true, sir? INR has been, the INR has been devised to monitor the required intensity of anticoagulation for sure, but in because INR comes with the INR, how it is calculated based on the international standards, so it will also be useful for patients who with active DIC with regard to coagulation factor replacement. So INR less than 1.5 is what is mandatory or optimal or our target, or if the PT less than 1.5 times the control value is what we are looking for with various these factor replacements. So I think most of the queries on the platform we have addressed. So are there any further queries or questions from any of the faculty on this virtual platform today? You can unmute and you can ask directly also if you feel so. I think we have addressed most of the queries. I thank all of you for August gathering on virtual platform today, and I conclude this talk by with the message to stay safe and take care. And again, thank you Intas Pharmaceuticals for bringing out putting all of us together on this virtual platform. And Intas team, you want to conclude the session?
Sir, thank you, sir, for first of all providing us opportunity to be the valuable knowledge partner for such a wonderful talk and presentation. It was all our pleasure, was all ours. We were able to host such a large audience and we will able to provide a platform where the things and queries can be served. Very soon we will be sharing the links, edited links and everything with you, sir, so that all the audience who are requested for the recording can be get benefited, and we will circulate it to other various platforms so things message can be spread out. Sir, we will definitely look forward for many months for such further interactions with you, sir.